Welcome all to the today's session. So today's talk is on birth after previous Caesarian section. It is a Green Top guideline number 45 published in October 2015. Okay, we begin with our quote, Master MRCOG with concept-oriented clarity. So we will clarify all our concepts from this particular guideline. Okay, so coming to the VBAC. So whenever such patient is there with a previous Caesarian section, what we have to do, we have an option of vaginal birth after Caesarean section or elective repeat Caesarean section. So there has to be some checklist, and that checklist we need to go through during the counseling. Okay, and then we will do the decision making and we will document it. Okay, so during antenatal care, always VBAC versus ERCS, that is elective repeat Caesarean section checklist is used, and counseling is done and decision making is performed and everything is documented. Okay, which are the patients who are suitable for VBAC? Remember here, this is the most important thing. So which patients are appropriate? Most women with singleton pregnancy with cephalic presentation, more than 37 weeks of gestation, and single prior lower segment Caesarean section. Okay, these are the most suitable patients for vaginal birth after Caesarean section. That is singleton pregnancy, cephalic presentation, more than 37 weeks of gestation, and single prior lower segment Caesarean section. When more than one or two Caesarean sections, there are certain things which are mentioned in the guideline that we will also cover later on. Okay. Now, which are the contraindications? Okay. So specific contraindications, remember, if there is a previous rupture and the placenta previa. Okay. So previous uterine rupture, classical Caesarean scar, and major placenta previa. Okay, so these are the three contraindications: previous uterine rupture, classical Caesarean section, and major placenta previa. Then, in cases of complicated scar, like you have previous inverted T or J-shaped incision, then there will be case-to-case review by the senior obstetricians. Okay, so the cases where there is a complicated uterine scar, they will be reviewed by the senior obstetrician, and then case-to-case review will be done. Otherwise, these are the three contraindications for VBAC. Then what about more than two or more than two previous Caesarean sections? VBAC can be offered after senior counseling, delivery only in centers with immediate surgical backup. Okay, so again, senior counseling is required in these particular cases. Then what are the risk factors for uterine rupture? Okay, so assess individually if additional risk factors are present. Until we have to counsel the patient, and always document the discussions and final decision before the delivery. Plan for labor before schedule elective ERCS date. Okay, so if the patient goes in labor, she may be offered this. There is chance that you have posted this patient for elective repeat Caesarean section, and she may go in labor. Then what should be the plan? That should also be discussed and documented. Okay, and always use VBAC checklist and provide patient information leaflet. Okay, so now what are the risks and benefits of both VBAC as well as repeat Caesarean section? So if the patient undergoes successful VBAC, so when the patient will undergo successful VBAC, it has got a lowest complications, while the highest complication will be there if the patient is posted for VBAC, but if the patient is posted for VBAC but undergoes Caesarean section. Okay, so have you understood? The Caesarean section during the VBAC will have the highest risk. Okay, so VBAC, what is the rupture rate? It is 0.5%, that is 1 in 200. So rupture rate is 0.5%. Can anyone tell me where in obstetrics we have come across 0.5% prevalence of various conditions, somewhere between 0.5 to 0.6%? Any other condition which we have discussed? Any idea? What is the prevalence of shoulder dystocia? What is the prevalence of cord prolapse? Okay, just check it, all those prevalences, and compare. Okay, that will be less than 1%, somewhere around 0.5, 0.6%. So VBAC risk of rupture is 0.5%, that is 1 in 200 Remember, this can be asked as a SBA. Now coming to the perinatal death risk. Perinatal death risk in VBAC is very low. It is similar to the first time delivery or primary first time mothers. Okay. Now coming to the elective repeat cesarean section. Now this patient who has got previous cesarean section, there will be increased risk of placenta previa, accreta in the future. Chances of adhesions and neonatal respiratory morbidity will be there, especially if you conduct the delivery before 39 weeks of gestation. And what is the likelihood of success of VBAC? Again, this is a SBA, numerical SBA. Success rate is 72 to 75%. Now here, please remember one thing. If you are asked about the success rate of the VBAC, don't answer this figure blindly. Okay, you have to remember this particular figure, but read the scenario carefully, because success rate differs with different scenarios. So read the scenario carefully and then answer. Okay, I'll discuss further in detail. Say for example, this line. So best predictor is the previous vaginal delivery. This can be asked as a question. SBA, what is the best predictor? If the patient has got previous one vaginal delivery followed by cesarean section, or cesarean section followed by one vaginal delivery, then the VBAC success rate is 85 to 90%. Okay, and it has got a lower rupture risk. So whenever VBAC success rate is asked, always go through the scenario what happened. This is in general. Okay, is given 72 to 75%, but if there is a previous vaginal delivery, your answer will be 85 to 90%. Now coming to the intrapartum management. So conduct VBAC equipped obstetric unit with continuous monitoring along with the immediate cesarean section facilities. Then unplanned labor after cesarean section. Okay, those cases are to be reviewed by the experienced obstetrician. So the patient goes in labor. In those cases are to be reviewed by the experienced obstetrician. Epidural can be given, but with epidural we have to remember a few things, that if the dose requirement is high, then think of rupture uterus. Okay, so or scar rupture. So increasing requirement of the analgesia may suggest rupture. Continuous electronic fetal monitoring from onset of labor. So this is one of the indication for continuous electronic fetal heart rate monitoring. So VBAC here, these rupture risk 0.5%, that is 1 in 200, 72 to 75%, previous vaginal delivery, and 85 to 90%. These 4 or 5 things can be asked as a SBA. Okay. Just a moment, someone. Yeah. Now we go ahead. Now what about the augmentation and induction in cases of VBAC? Okay, so can we go ahead with induction or augmentation? What the guideline says, induction and augmentation will increase the risk of rupture by 2 to 3 times, while cesarean section risk is increased by 1.5 times. Okay, 1.5 times there is a higher risk of cesarean section, and 3 times higher risk of uterine rupture if you induce the cases of previous LSCS. Okay. Then senior obstetrician must discuss the decision of induction, method of induction, oxytocin use, monitoring intervals, and criteria to stop VBAC. Okay, so if the patient wants induction for some other the reason, we have another next topic that we will come to know what are the indications for induction. But by any chance the induction is required, then we have to discuss these 3 things: 2 to 3 times higher risk of rupture, and 1.5 or 1.5 times higher risk of cesarean section. Okay, then what the methods can be preferred? Preferred methods will be amniotomy or Foley's. These will have a lower rupture risk than the prostaglandin. Okay, so there may be scenario where the patient is insisting for induction, or there is a need for induction for some reason, and patient doesn't want cesarean section. Okay, so they may ask you the method of induction. So method of induction will be, preferred method will be mechanical methods. Okay, amniotomy and Foley's. Then coming to the elective repeat cesarean section. What is the timing? Timing is always at 39 weeks. Give antibiotics before skin incision. Provide thromboprophylaxis as per RCOG guidance, and placenta previa with prior cesarean section. We need to look into these cases, early recognition, multidisciplinary care, and informed consent is essential if you have a placenta previa along with prior cesarean section. Okay, because you have to rule out the placenta accreta spectrum in these particular cases. So special circumstances, caution with VBAC. Which patients you will be very cautious? Patients with post dates, twins, macrosomia, stillbirth, and maternal age more than 40. Okay, so maternal age more than 40 actually has got a less success rate, and even macrosomia, twins, these cases are high risk for the rupture also. If there is a preterm VBAC, it has got a similar success rate as comparable to the term VBAC, and also it has got a lower rupture risk also. Okay. Now, what we have seen up till now was just an executive summary. Now we'll go into the details of the same. Okay, so here, if you remember, if you see here in this slide, so they have mentioned about the Caesarian section rate in the United Kingdom. So overall, if you see, they have mentioned 25.5% Caesarian section rate in the England, and that is around 15% of emergency and 10 to 11% of elective. So that constitutes the total Caesarian section rate in the England, and it is almost same Wales and Scotland, etc., etc. Okay. Now, what is the consensus among? There are various guidelines in cases of these Caesarian sections having subsequent pregnancy. So NICE, RCOG, ACOG, what does they say? Planned VBAC is safe for most women with a single previous lower segment Caesarian section. So the consensus on all from these guidelines is that planned VBAC is safe for most women with a single previous lower segment Caesarian section. So it is supported by health economic, because you know, the cost will be cost effectiveness will be there and all these things. Now let's go into the antenatal care schedule for these patients. Okay, so always use the checklist for VBAC as well as ERCS. Okay, and document the counseling also. Whatever the decision is made, that should be documented. Follow NICE antenatal guidelines with specific reviews as needed. Counseling usually after mid-trimester scan by maternity team, and you have to involve senior obstetrician if there is a contraindication to the VBAC, if there is an uncertainty about the mode of delivery, if the patient is requesting for the elective repeat Caesarean section, or if the induction is required mainly after 41 weeks of gestation. Okay, suppose the patient has opted for VBAC but does not deliver up to 41 weeks of gestation, then we may require induction, and all those things what we have discussed in the last slide, that needs counseling. Okay, then other pregnancy complications like the patient has got preeclampsia, breech, FGR, macrosomia, etc., and the final decision whatever is made on the birth is generally by 36 weeks. So from the mid-trimester scan only the discussion will start, then it will continue throughout the antenatal period. Everything will be documented, and the final decision on the mode of the birth by 36 weeks will be discussed, and the senior obstetricians will be involved in certain cases whenever there is a contraindication to VBAC, where there is uncertainty about the mode of delivery, if the patient is requesting ERCS, or if the induction is required, or there is a obstetrical complications. Okay, always give patient information leaflet. Actually, this is for part 3. So whenever the counseling comes, then after that next step is a patient information leaflet mentioning the success rate, risk, and options. Okay, so these are the things which are there. Then which are the patients who are suitable for planned VBAC? Okay, so this we have discussed in the summary. Those cases are singleton, cephalic, more than 37 weeks, single previous lower Caesarean sections, with or without prior vaginal delivery. Okay, evidence supports VBAC as a safe and appropriate for majority of the patients. Always review previous Caesarean section record and look for current pregnancy complication to exclude the contraindications. This is the most important. You have to review the previous records and see what exactly this pregnancy is, including the BMI of the patient, including the whether she is post-dated, whether she has got any obstetrical complication, etc., etc. Because guidelines says single, cephalic, more than 37 weeks, and previous single lower segment. So these are most appropriate patients. Okay, so what are the contraindications? We have seen 3 contraindications. Previous uterine rupture, it has got a rupture risk of more than 5%. Remember, the rupture risk is more than 5%. Okay, 5% or more in cases of if there is a previous uterine rupture. In classical Caesarean section scar and major placenta previa, these are the 3 contraindications for VBAC. Rest of the contraindications are relative. Like if it is a complicated scar like an inverted T, J-shaped, low vertical or extensive extension, in that particular case what is required is a senior's review, and then they will be deciding the mode of delivery. If it is a previous uterine surgery, myomectomy with cavity breach, histoscopic septal resection, etc., the rare rupture, but the risk is uncertain. Okay, in these cases the risk is uncertain, so the senior's review is required. Okay, then placenta related risk after Caesarian section. Now she has undergone previous Caesarian section. What is the risk in this particular pregnancy? Again, here is a SBA. Okay, placenta previa risk increases with the number of Caesarian section. There is a 1% risk of placenta previa after one Caesarian section, 1.7% after two Caesarian section, and 3 plus Caesarian section, it is 2.8. You can remember 1%, 2%, 3% approximately for placenta previa. Okay, so the risk of placenta previa after one Caesarian section 1%, after two Caesarian section 1.7, after three Caesarian 2.8. Okay, again SBA here. Placenta accreta risk is high with previa plus prior Caesarian section. Now we are talking about placenta accreta risk. So the patient has got placenta previa with prior Caesarian section. The risk of placenta previa, again, it has got association with previous Caesarian section. It is around 11 to 14% with one Caesarian section, 23 to 40% with two Caesarian section, and up to 67% with 5 or more Caesarian section. Okay, so these are the risks. This also we have seen in our last lecture, which we have taken on the placenta accreta spectrum. Okay, so placenta previa and placenta accreta spectrum that we have already covered. Okay, now what does the guideline says about VBAC after two Caesarian section? Okay, so VBAC can be offered after senior obstetricians counseling in cases of previous two Caesarian section, but there is an increased risk of uterine rupture and maternal morbidity is more. Success rate is around 62 to 75%, which is almost similar to single Caesarean section if prior vaginal birth is present. Okay, the risk of uterine rupture here is 1.36%. So what we have seen is a 0.5% with a single Caesarean section, but the risk of uterine rupture is 1.36% after two Caesarean section. Morbidity is increased. The chances of hysterectomy transfusion are also increased. Then labor will be conducted only in centers with immediate surgical back. Women with planning multiple future pregnancies, the VBAC is best because it will reduce the long-term risk of placenta previa, placenta accreta, and hysterectomy compared with the elective repeat Caesarean section. Okay, so these actually the patients who are planning multiple future pregnancy, VBAC is best. Okay, then risk factors for uterine rupture. Now just concentrate on these particular factors, what they have mentioned about the uterine rupture. So possible risks are the short interpregnancy interval less than 12 months. Okay, so if there is a short interpregnancy interval less than 12 months, or the post-date patient is there, maternal age is more than 40, obesity, low Bishop score, macrosomia, and thin lower uterine segment. Okay, so these are the patients or the possible risks for the uterine rupture. Short interpregnancy interval, post-dates, maternal age more than 40, obesity, low Bishops, macrosomia, thin lower uterine segment. Now short interpregnancy interval also has got a increased preterm birth. Okay, then lower uterine segment thickness. Okay, if there is it is less than 2 millimeter, there is a high risk of rupture. If it is 3 or 4 millimeter, in that case it is protective. However, there is no universal cutoff. Okay, so as such there is no universal cutoff, but what has been observed, less than 2 millimeter there is a higher risk of rupture. More than 3 or 4 millimeter, generally it is protective. So these factors, the presence of these factors do not contraindicate VBAC, but should guide counseling and induction augmentation decisions. Okay, so even if your scenario mentions this, it is always a joint or the shared decision making. Okay, so this is not a contraindication VBAC, but we have to include this into the counseling and induction augmentation decision. Okay, now what the antenatal counseling? We will do the antenatal counseling as per the checklist and document all the counseling and final decision before the delivery. Plan for labor. If the patient goes in labor, then what will be the plan that needs to be discussed? use VBAC checklist and patient information leaflets to ensure informed consent, tailored discussion with respect to medical history, chance of VBAC success, and future reproductive plans. And always these particular things they are going to ask in the examination, that is, what are the risks and benefits of VBAC and elective repeat cesarean section at or after 39 weeks of gestation. So in general, if the VBAC is successful, it has got the lowest complication, and the risk will be highest if the VBAC is failed and requires cesarean section. Okay, so these particular figures, so this particular slide, you can take the photograph, and most of the numericals are here, SBAs are here. Now, what are the risks in VBAC? Okay, rupture risk we have mentioned 0.5%, that is 1 in 200 with a singleton, single previous cesarean section. What about previous 2 cesarean section? How much is the risk with what we have discussed in the last slide? Anyone?
1.36.
Correct.
1.36.
Okay, 1.36 with previous 2 cesarean section. Okay, so if the patient goes in spontaneous labor, the risk of rupture is 0.4%. Okay, so this is overall risk which they have mentioned. The spontaneous labor is 0.4 to 0.5% they can give. Then if the labor is induced, it is almost 3 times high, that is 0.5 to 1.4%. Okay, if the labor is induced, the risk of rupture is 0.5 to 1.4. If it is augmented, 0.9 to 1.9. So it is 2 to 4 times higher of this. Okay, 2 to 4 times of higher. See, here it is 3 times higher of this. So always remember these particular figures from this point of view. So this lecture and next lecture, I'll be telling you how to remember. If you remember this, just remember how they are correlated to each other. Okay. Then perinatal death risk is in VBAC is extremely low. It is similar to other first-time mothers. And unsuccessful VBAC will increase the risk of rupture, hysterectomy, transfusion, and infection chances are high. Hysterectomy is required in 14 to 33% of the ruptured cases. So if you have a rupture, almost 1 in 3 to 1 in 6 patients will require hysterectomy. Okay. Now, what are the problems with elective repeat cesarean section? Okay, in elective repeat cesarean section, the perinatal death risk is less, but there is an increased neonatal respiratory morbidity if you conduct this before 39 weeks of gestation, but that can be covered with the use of antenatal steroids. Okay, now long term, there is an increased placenta risk with ERCS, placenta previa, accreta, adhesions, surgical difficulty in future pregnancy. So these are the risks. Now, what about the blood transfusion? With VBAC, there is a slightly increased risk of blood transfusion, around 2% versus 1% in elective repeat cesarean section. So VBAC has got a higher risk of blood transfusion. Okay, hysterectomy risk overall it is not increased, but if the rupture occurs during the VBAC, then definitely the risk of hysterectomy is increased. Okay. Now this particular slide also has got many figures, but not all figures will be asked, but certain important figures you should know. Now coming to the adverse outcomes. Okay, what are the adverse outcomes during VBAC? Okay, chance of antepartum stillbirth, extra 10 every per 10,000 risk after 39 weeks while awaiting the labor. So it comes to around 1 in 1,000. But when there is a stillbirth or perinatal risk, they always calculate per 10,000. So it will be 10 per 10,000. If the patient, if the patient does not undergo spontaneous labor by 39 weeks of gestation, we are awaiting for the spontaneous onset, and the risk of stillbirth will be increased to the extent of 10 per 10,000. Okay, is it clear what exactly they want to say? The risk of stillbirth, if you wait more than 39 weeks of gestation, because this patient is posted for VBAC, so we are going to wait. Okay, the risk of stillbirth will be 10 per 10. Delivery related perinatal death is less with the VBAC, around 4 per 10,000, but it is less with the ERCS, it is less than 1 per 10,000. Okay, so this 4 you can remember with VBAC. Okay, then 1/3 of VBAC deaths linked to the uterine rupture. Risk of death from rupture is around 2 to 16%. HI is around 8 per 10,000 in VBAC. Okay, and 60% cases are due to the rupture, and composite adverse outcomes, that is more these outcomes happening together, the chance is 3 times higher with VBAC as compared to the elective repeat Caesarean section, but the absolute risk is small. Okay, so out of which what we can remember is a stillbirth risk is around 10 per 10,000 after 39 weeks of gestation. Then perinatal death is around 4 per 10,000, and HIE risk is around 8 per 10,000. Remember, this is 10, 4, 10, and 8. These are related to the VBAC. So antepartum stillbirth 10, perinatal death 4, and HIE 10 with respect to VBAC. Okay, all are even figures 4, 10, 4, 8, and 10. HIE is 10. Okay, so now coming to the elective repeat Caesarean section, maternal mortality is slightly increased versus VBAC. Now, vaginal delivery we know is safer. So even if it is VBAC, the maternal mortality will be less, and operative with Caesarean section, the mortality will be increased. So it is 13 in elective repeat Caesarean section, while it is 4 per 1 lakh. So mortality is always per 1 lakh. Okay. So in VBAC, mortality is 4 per 1 lakh, while in Caesarean section it is 13 per 1 lakh. So this figure is important. They have asked these figures in past papers. Okay. Neonatal respiratory morbidity is higher in elective repeat Caesarean section, especially if you carry out before 39 weeks of gestation. So TTN, transient tachypnea of newborn, 4 to 5% in ERCS, while 2 to 3% in VBAC. RDS is 0.5%, while in VBAC it is 0.05%. Now this risk is as per the gestation at 37 weeks it is 11.4, this TTN risk. Then 38 weeks it is 6.2%, and 39 weeks it is around 1.5%. Okay, so future pregnancy risk will be increased placenta previa and accreta risk, adhesions, and surgical complications. So these are the risk with the elective repeat Caesarean section, where you should remember the mortality. This mortality they are going to ask. Okay, the TTN is high with Caesarean section, 4 to 5%. RDS is also high, 0.5% in ERCs, and they are very less in cases of VBAC. Okay. Now, summary, same thing what we have discussed. Overall success rate is 70 to 75% that we have seen. Same slide is repeated. Okay. What are the best predictors of the VBAC? Previous vaginal birth, 85 to 90%. Okay. Lower success rate is with induction, BMI more than 30, no prior vaginal birth, labor dystocia, advanced age, and high birth weight. This has got a lower success rate. Best predictor, previous vaginal delivery, and 85 to 90%. Other favorable factors, same, like opposite to this. Maternal age is less than 40, BMI is less than 30. If it is a spontaneous onset, vertex presentation, station is low, bishop is good, malpresentation as per as prior Caesarean section indication. So if she has got a previous indication for malpresentation Caesarean section, then thus it is favorable in this particular case for VBAC. Okay. Ethnicity, higher success rate in white compared to the black women. Then there are prediction tools, but these are not routinely used. They have got a scoring based on the bishop's age, indication for Caesarean section, BMI. These are not asked. Okay, so I'll not go into the details. Okay, now coming to the intrapartum management. So planned VBAC only in equipped delivery suites with 24/7 staff. Monitoring is must, and immediate C-section facilities and neonatal resuscitation facilities should be available. Unplanned labor after Caesarean section, the decision should be taken by the senior obstetrician. Epidural is permitted, but if you are getting or noting that there is a high need of analgesia, think of whether it is a case of uterine rupture. Okay, then VBAC, intrapartum monitoring and analgesia, okay, is must. Monitoring, continuous electronic fetal monitoring is one of the indication is a VBAC. Okay, will give continuous one-to-one support, IV access, blood test, etc., etc. Cervical assessment, normal labor progress every 4 hours. Again, epidural may increase the risk of second stage delay and instrumental delivery. Earlier catheter placement is useful. It will provide labor analgesia as well as operative anesthesia also. But there is a conflicting evidence on VBAC success rates, and frequent top-ups may signal uterine rupture. Okay, this also we have seen. Okay. So always look for CTG in these cases. Okay, CTG abnormality is another question. The next question I think is here. Okay, on this slide. So now coming to the uterine rupture, how to recognize and risk. Okay, so signs will be abnormal CTG present in around 66 to 76% of cases. So they may ask you this, the sign of uterine rupture. So abnormal CTG, 66 to 76%. See, other will be severe abdominal pain, especially persisting between the contractions, scar tenderness, vaginal bleeding, hematuria, cessation of contractions, maternal tachycardia, shock, loss of station, change in abdominal counter, absent FHR at usual site. Okay, so they may give you this put together, but the answer will be abnormal CTG around 66 to 76% of cases. Now, what is the risk of rupture in singleton? What we have seen, 0.5% during planned VBAC. Okay, if the uterus is unscarred, in that particular case, 2 per 10,000. Okay, then if it is a case of elective repeat cesarean section, it is 0.02%. 90% rupture occurs during labor around at 4 to 5 centimeter. Okay, 90% of the ruptures will be around 4 to 5 centimeter stage. So early recognition, laparotomy, neonatal resuscitation, these are the important steps. Ideally, you have to deliver the baby within 18 minutes of the your decision, and the classic triad will be pain, bleeding, FHR abnormalities. Okay, so this triad is seen, but only in less than 10% of cases. This is what actually they say, that less than 10% will have this particular triad. Now coming to the decision of induction and augmentation, certain things during the executive summary we have already seen that there is increased risk of uterine rupture 2 to 3 times, 1.5 times increased risk of Caesarian section. Okay, and higher rupture risk if there is no previous vaginal birth, or if we have used the prostaglandins, or high dose of oxytocin will have a 4 times increased risk of uterine rupture. Okay. Now, what are the methods? Safe will be amniotomy or Foley's catheterization. These are the mechanical methods rather than prostaglandins. Prostaglandin rupture risk is high. So these figures are not asked, so I will not go into the details of this. And the counseling by the senior obstetrician is must. Okay. Then planning and conducting ERCS. What we have seen up till now is a VBAC. Now let's talk about elective repeat Caesarian section. It is timing will be around or after 39 weeks of gestation. Antibiotics is required before skin incision. The antibiotic of choice is a cefuroxamine plus metronidazole. This can also be asked as a SBA. Okay. Avoid co-amoxiclav due to any serious necrotizing enterocolitis can happen. Okay. So thromboprophylaxis as per the RCOG guideline. Then placenta previa and accreta, early recognition, placenta multidisciplinary approach, informed consent, and as per the RCOG we are going to manage. Okay. Now, if you delay the Caesarean section from 38 to 39 weeks, so we have seen they recommend the Caesarean section at around 39 weeks because the respiratory morbidity is less. If you carry out at 38 weeks, the respiratory morbidity is 6%. That will be reduced to 1% just by waiting for 1 week. But slightly increase antepartum stillbirth to this extent, 0.05%. Okay. If ERCS is before 39 weeks, consider maternal corticosteroids. Betamethasone reduces respiratory distress by around 50%. So if you buy for any reason you want to do before 39 weeks, the maternal corticosteroids will be used. Now coming to the special circumstances, what we have seen up till now was a just otherwise low risk case apart from Caesarean section. Now, if you have a case more than 41 weeks of gestation, then what is the role of induction? Induction reduces the perinatal mortality in general, but in women with prior Caesarean section, higher risk of emergency Caesarean section, almost 1.5, and risk of scar rupture is 2 to 3 times. So always senior review at 41 weeks. Consider provisional ERCS versus induction depending upon the cervix and maternal and fetal condition. So it is a senior decision. Okay. Then in case of twin gestation, VBAC success rates are similar to singleton, around 45 to 84%. However, the guideline specifically mentioning or the guideline is suitable for singleton cases. But for twin gestation, they mention the VBAC success rate is similar to singleton. What about fetal macrosomia? That is more than 4 kg. Risk of uterine rupture is increased. Odds ratio is around 2.6. Failed VBAC is around 2.5 odds ratio. Okay. And shoulder dystocia, severe parental tear, these are increased. Success rate is less than 50% with fetal macrosomia. So if you have asked the success rate and expected birth weight is more than 4 kg, the success rate will be less than 40%. So just don't remember one figure of 72 to 75%. Please remember other figures also. Okay. Then antepartum stillbirth, high VBAC success rate around 87%. Rupture risk is around 2.4% if induction or augmentation is required. So if there is antepartum stillbirth, you still can go ahead with the VBAC. The success rate is good. Okay. But the rupture risk is also higher, provided the induction or augmentation is correct. If it is a spontaneous, then success rate is good. Okay. Maternal age more than 40 years, higher risk of stillbirth and failed VBAC. Then consider delivery by 39 to 40 weeks. Okay. Then preterm VBAC has got a similar success rate, around 73%, and risk of rupture is also less in preterm. So preterm VBAC is same success rate. Okay. Now there are certain charts and tables from the guideline, out of which this you can remember VBAC success rate is 72 to 75% and uterine rupture is 0.5%, what we have discussed. Okay. The induction and augmentation will have higher. Okay. Then just wait a moment. I think someone is here. So here, birth choices after Caesarian delivery pathway. Successful VBAC 3 out of 4 or 72 to 75% success rate. Successful VBAC after one previous one vaginal birth, it is 85 to 90%. Successful VBAC is more likely in unsuccessful VBAC is more likely in induced labor, no previous vaginal delivery, BMI greater than 30, previous Caesarian for labor dystocia. If all these factors are present, remember success rate is around 40%. So if you have a multiple factors in the scenario, the BMI is high, then it is an induced labor, then the success rate is 40%. So 1, 2, 3. Okay, here these three figures are important. The risk of uterine rupture is 0.5% in VBAC. In ERCS is less than 0.02%. BT risk is high in VBAC, around 2%. Here it is 1%. Serious complication, maternal mortality we have seen, here it is 4 and here it is 13. So these two figures are also important. Okay. This figure, these three figures. Okay. Then transient respiratory morbidity 2 to 3% in VBAC, while ERCS it is little higher, 4 to 6%. Antepartum stillbirth 10 per 10,000, it is not applicable here. HI is around 8, here it is less than 10, less than 1 per 10,000. Okay. So these are the important points. Then definitions, this actually not from SBA point of view, so I will skip this. This also we have discussed what exactly we have to do mid-trimester scan, then discussion will start from here. Then not only that, we have to look into the placenta, repeat scan at 32 to 34 weeks if it is a low-lying placenta, and always have a discussion with the seniors. So the same thing is mentioned here. Always obstetrician review at 36 weeks of gestation to determine the mode of delivery for women who opted ERCS or undecided on mode of delivery or have complicating obstetric and medical disorders. Okay, so this obstetrician led assessment at 36 weeks of gestation. After 39 weeks, performing ERCS, then what are the advantages and disadvantages that we have definitely seen. By any chance, if the patient does not go into the labor or the patient has wants to wait further, in that particular, again at 41 weeks, senior obstetrician led assessment is important. who had opted for planned VBAC but have not gone into the spontaneous labor. Risk and benefits of various options are discussed and documented. Options include membrane sweep, prostaglandin, amniotomy, or Foley's catheter induction of labor. Okay, or she can have ERCS, or she can also have expectant management. So all these are the options which are available. Okay, and it is always a shared decision making, but still these are safer. Amniotomy plus Foley's will be safer, but still the patient, if she chooses to wait, then that also her wishes are also to be respected. Okay. So here same success rate, everything is duplicated, so I will not go into that. Okay. Again, here this risk we have discussed. Okay. Yes, here risk of anal sphincter injury in women undergoing VBAC is 5%. Remember, risk of anal sphincter injury in VBAC is 5%. Okay, birth weight is the strongest predictor for this, and the rate of instrumental delivery is also increased up to 39% in VBAC. Okay, so sphincter injury 5%, birth weight strongest predictor, and instrumental delivery rate 39%. All 4 and 13 we remember. Now this everyone should, no one should forget these two figures, 4 and 13 for maternal mortality. VBAC is less, Caesarian section is high. Again, these figures we have gone into details. HIE is 8, okay, and 4 is for perinatal death in VBAC. Okay, so that finishes the topic along with various numerical questions from VBAC. Thank you very much.